Cunningham, and I'm the Executive Director of the Center for Bioethics and Human Dignity, a Christian bioethics research center here at Trinity International University in Deerfield, Illinois, just north of Chicago. I'm so pleased to welcome you to our webinar, which is sponsored by Her Dignity Network. Joining me here in the studio is Jennifer McVeigh, our Event and Education Manager. Dr. Michelle Kirtley, Bioethics and Public Policy Associate, joins us from Washington, D.C. Glory Diaz, our Communications Manager, is going to help us keep things running smoothly during the webinar. I would just like to take a minute to tell you about Her Dignity Network. It's the result of the collaboration of many people, including probably some of you here in our audience. And as part of the Center's initiative in global women's health, Her Dignity Network has a vision of a world where the full dignity of girls and women, as equally made in the image of God, is reflected in their access to essential health care and appropriate biotechnologies and their protection from medical discrimination and exploitation. So we invite men and women around the world to join the network as a sign of your support for the equal dignity of girls and women and equal access to essential health care. And you can sign up on the website at herdignity.net. Our current campaign features positive efforts to reduce maternal mortality and increase infant survival. So as part of this campaign, today's webinar is going to feature a project in Nicaragua that's going to highlight the important role of men who can help their wife have a healthy pregnancy and safe delivery and help their newborns have a stronger chance of survival. You might remember that tomorrow is International Women's Day, and what better way to honor women and girls around the world than to affirm their dignity, but also the important role of their fathers, their husbands, and their sons. Before I introduce our guest speaker, let me briefly explain what will happen. First, Dr. McEwan will present her project, Father's Vital Contribution to Improving the Health and Safety of Mothers and Newborns, and she is joining us from Nicaragua. We will see her slides, but we won't have video of Dr. McEwan. Her presentation will last about 30 minutes. At the end, she's willing to take some questions. So listen, as questions come to your mind, you may enter them in the Q&A box. Dr. McEwan will try to answer as many as possible, but if she can't get to them all, we will pass them along to her. Then we will show a 15-minute video of the project in Nicaragua. You're going to want to see this. It adds faces and life to what you've just heard her talk about. There will be one final question just before our hour is up. And that question will be on how we can pray specifically over the next 30 days. And now let me introduce Dr. McEwan. Dr. Elena McEwan is a physician by training. She specialized in pediatrics and trained in her home country of Nicaragua, finishing in 1995. Since 2006, Dr. McEwan has served as the Senior Technical Advisor in Maternal and Child Health and the Technical Backstop to Maternal and Child Health projects for Catholic Relief Services. Her primary purpose is to provide global leadership to CRS's maternal and child health programming. Elena also coordinates and provides technical support to CRS's awarded maternal and child health grants. More specifically, she provides technical assistance to develop the detailed implementation plans, the social and behavior change strategies, and evaluations and operations research. As you can tell, she is quite accomplished. She also represents Catholic Relief Services and their maternal and child health portfolio in global forums around the world, such as the Gavi Alliance and the Core Group. And so without further ado, I will turn the microphone over to Dr. Elena McEwan. Welcome.
Thank you very much for your kind words, and thank you everyone for taking the time to listen what the communities and the households in Nicaragua have done to improve newborn survival. So the first slide is going to show you what we have done in Catholic Relief Services in Nicaragua in partnership with the Ministry of Health and Caritas Matagalpa. This is a project that ran from September 2008 to September 2012. The goal of the project was to contribute to the reduction of maternal and newborn morbidity and mortality by 2012 in targeted area. The target groups were women of reproductive health age 41,000 women of reproductive age, and their kids, 25,000 children under 5 years of age. The project was a comprehensive one that worked at the household, community, and facility levels, tried to organize a continuum of care to improve the survival of mothers and children. But the talk that we are going to discuss this morning is about the innovation that the Caritas Nicaragua in Matagalpa and CRS and the Ministry of Health and Communities developed in order to address the special needs of these people regarding access to care. As you can see, this is Matagalpa. In the black arrow is the Matagalpa department. It's in Central America. What is important to remember about this area? The Nicaragua is located in the Central America area. It's the second highest, poorest country in the Latin American and the Caribbean region after Haiti. The project area was more rural, isolated communities with difficult access because of road conditions. The literacy rate among adults was around 67%, and the women average of attending school was 2.4 years. These are very impoverished families with an average wage of working of $2 per day, and maybe sporadic work trying to do some kind of agricultural laborers in neighboring farmers. So most of these communities are not along these paved roads, but many of them were far off in the mountains, accessible only on foot or by mule. So try to picture what is the situation of these households who doesn't have easy access to health services, and especially during emergencies. The other characteristic of the project area, this is a post-conflict area. It was the center of the conflict, the civil war in the 80s. More of that, those households are male-dominated households. There was a huge amount of anecdotal information about domestic violence as well. And traditionally in Nicaragua, men take the decision in their family health and resources. So what we did was a baseline at the beginning of the project to try to understand what was going on and listening to the communities and households, what were their needs, what are the feasible solutions that they have. So CRS, Caritas, and the Minister of Health could help them achieve their dreams. As many of you may know, maternal morbidity and mortality is related to three main delays. The first one is delay in recognizing the danger signs and making a joint decision to seeking timely care. Most of these delays are related to household dynamics and gender norms. The second one is the delay in self-referral to seeking care. Most of the causes are lack of money to pay to transport, or lack of transport, or bad roads. The third one is the delay in receiving quality care, and main causes are the health staff skills or the resources to provide quality care. So unfortunately, the place that we work, all these delays were present. And the second delay and the third delay were easier to understand and trying to find feasible solutions. But the first delay, it was a very private one because it happens at the household level. So we decided to listen to the communities and ask men and women the same questions at the baseline. And we wanted to know if the decision to seeking care was influencing in the area and was contributing to the high morbidity and mortality for women and newborns. And we asked the same question, as I said before, and we found that only less than 50% of them mentioned that they made a decision together. So this is a thing to think about it, that less than 50% mentioned that they had made a decision together. And the project goal was that 100% of the couples planned during their pregnancies can make a decision where to seek care and plan well ahead of time all the resources that they need to put in place to ensure the household is well kept and they can safely go to the health center for all the services that the Ministry of Health is offering free of charge. So we decided to develop a hypothesis with the communities and the partners. And we decided that the main problem here was the situation of the male-dominated households. And our hypothesis was that if we focus our counseling on the fathers, and by increasing awareness among them regarding recognizing danger signs during pregnancy and newborn periods, and by motivating them to make joint decisions with their wives, will result in both seeking care during obstetric and newborn emergencies in a timely manner, and an increase in antenatal care, institutional deliveries, and therefore improving the maternal and newborn health. So keep in mind this hypothesis, because we are going to go back to this hypothesis later. So what we did at the beginning is, how can we understand better the situation? Well, the best way to do is to listen to the communities. So we did a formative research listening to men and understanding their situation from their lens, from their point of view. So approach using a male lens to identify the readiness to probe new behavior as well. So during the formative research, we listening to them about how they perceive their wife's pregnancy, what was their role during their wife's pregnancy, what was their role in taking care of their family's health and so on. And also, we decided to draft this innovation, providing a more central role to the husband during the pregnancy and delivery and so on, while not excluding the wife. It also brought a... Hello?
Elena, let me ask, when you were using this male lens, were there men on the project team who participated, or was it women, or a mixture of both?
Yes, we are going to describe this later, but just to give you an idea, the project, CRS project and Caritas project were the implementing partners in the ground, and both have men and women as a field agents. So we didn't have just men talking to men during the baseline. But the approach is a peer-to-peer approach, just men to men. And I'll discuss this later, why is the reason.
Thank you.
The other why this approach was disruptive was that we brought emergency care to the home. We brought the new stakeholders into the emergency maternal care, namely husbands and community-based providers. So the formative research was to assess the situation. As I mentioned, we identified what was going on. We took a picture of what was the situation from the point of view of men. And also we probed questions about their willingness to try new behaviors that were traditional roles for women only. The second phase was to develop a pilot. That was an approach to develop IEC materials, counseling sessions, and IEC materials to be used by the counselors as a job base to counsel men. So this was a small pilot that we did with men with some characteristics like men with pregnant women, husband with women who just had a baby or less than 1 month old. And when we identified this during this piloting phase, the feasibility of the innovation. And these are the behaviors that we decided to focus on because they was the one who had higher rate of practicing, of being able, the men who were participating in the pilot were able to practice it. So the third phase is the strategy launching, involving all the community members, involving all the stakeholders, all the people who are influential in the community. Let them know this is coming with the purpose of creating an enabling environment for men to practice those behaviors.
Elena, could you remind me what BCC stands for on your slide?
Yeah, sorry. It's the Social and Behavioral Change Communication Strategy. And it's a strategy that is intentional, that you decide which behaviors these persons would be more willing to try, and this will lead to better health outcomes. So there is a process of research, identifying the principal groups, identifying the key behaviors, identifying the key factors that influence these people to practice or not the behaviors and their willingness, and trying to negotiate with them which key activities they can implement in order to carry out these behavioral change processes. And as you know, behavioral change is not a linear change. It comes and goes, and you need to be reinforced, and you need to be supported by the people that you care to try the new behavior, to hold on to the new behavior, to adopt the behavior. So 3 key factors we use in order to promote these behaviors: knowledge from men and recognizing the benefit to them. So the benefit to them was not that the baby is going to be healthier, but the benefit to them is the prestige they were going to win among their peers as a good parents, as a good husband, as a responsive man. Those are the behaviors, the motivators that men were more willing to try new behaviors. The other one is the support from the wife, the household members, the community members, the health staff. And the other one is the skills. So in making sure that they have all the knowledge and the skills to do or try the behavior. So after we did the formative research and selected the behaviors, we launched the strategy, and we decided to select 20 communities in partnership with the Ministry of Health. These 20 communities were the ones who were really contributing to maternal morbidity in the area, very isolated areas, and also with the same characteristics that we have found in the area with the men and the household situation. So what is this innovation about? It's about a focusing on men, peer-to-peer counseling, tailoring to the needs of each individual man. So not all the men were practicing or probing the same behavior, but it was tailored to the needs of that household. So the first visit is when you go, a trained counselor, that is a volunteer from the community, comes to the household and make a presentation about this approach to the whole family, with the purpose of getting support from the families for these men. After they have talked to the family, and the family have an answer to all their questions and problems or some kind of doubts, when everything is fine, when the family agrees, you ask permission to the family to talk directly to the man by setting it aside. And in that first visit, you just negotiate with him if he would like to try to get some more visits from this BCC counselor, behavioral change counselor, and set a new date. So for the next visit, the trained counselor, already with the BCC materials, he does the diagnostic. Why do I say he? Because it's a peer-to-peer counseling. So we decided to choose men to counsel men. And who are those men? Those men are the ones who are really practicing those behaviors. Most of them were lay religious men, very well respected in the family, selected by the communities to become their counselors, who were trained by Caritas staff and Nica Salud, another NGO in Nicaragua, and CRS, in counseling techniques. So these men who are well respected, who become a model for these other men, are the ones who have the respect from them, and they were more willing to listen to. So the second visit, the counselor brings a simple, as you can see here, a simple tool. Later on, they did a nicely pictures, but at the beginning, it was a simple tool for the man to choose of the menu that I showed you before, which behavior he was willing to try. For example, if the man has a wife in the first trimester, our priority behavior for this man to try is to seek antenatal care as soon as possible. If the wife is in the second trimester or third trimester, is to continue seeking antenatal care, to take all the medicines that was prescribed by the health center. As I said again, it's free of charge. To keep adherence to all the medicines, vitamins, and vaccines that were also given by the health staff. If the wife, on the other hand, is near to the delivery, is to seek antenatal, is to seek the health center for institutional delivery. So every man was practicing a different behavior. So the second visit was when the man decided to choose the behavior and make an agreement written agreement like this one, I, Freddie Oporta, will be present during the labor and delivery of my baby. This is a big thing for us because it's in the policy, but it was not happening. So there is a huge gap between the policy, the written policy, and what is happening in the health centers. And when we discuss and we listen to the men, they were saying that they didn't perceive their role going to the health center with a wife. They always thought that was a role for the mother-in-law to accompany the woman, but he was just his role during pregnancy was to provide the money and resources for them to seek care. So this was a big thing for us, for him to go inside the labor and delivery ward. And the subsequent visits were reinforcing visits. When you come, if you agree with a man that the counselor is going to come every week or every 2 weeks, then you go through the agreement and ask the man if he was able to do the behavior, how many times as agreed, what were the barriers, if he couldn't practice the behavior, and if he can do the behavior, continue reinforcing this good parent, good husband, decent man in the community, in order for him to keep being proud of himself. Until the behavior doesn't need to do it again. For example, if in this case it's going to the labor and delivery ward and they went and they had the baby and they came back, then the counselor choose another behavior. For example, taking the baby to the newborn care first visit and so on. The other things that we try to mix also with these seeking care behaviors that were the main focus of the project is trying to help the wife during pregnancy with the household tasks that were assigned just to her. For example, to bringing the water, bringing the firewood, cooking for the kids, feeding the older kids, taking care of the baby, for the woman to rest a little bit. And those behaviors were also practiced. And also we would really had to create that safe environment for men to feel that they were recognized for that. Because believe it or not, there were women laughing at men because they were saying that why they were doing that. Sometimes the wife felt that that was their role. So we really had to negotiate with all of them, making sure that they knew that this was something good for everyone, that the family was going to win at the end. The other behavior that we had to negotiate was the seeking care, the getting into antenatal care and institutional deliveries, because some medical doctors and nurses, even though they were already trained, they didn't allow them. So the man was there in the health center, but the nurse or the doctor said, no, you are not allowed to get into the labor and delivery room. So there was a lot of building allowed around the supporting groups for these men to make the behaviors. So once we implemented the innovation, we did an operations research at the beginning and at the end of the innovation to measure if this approach is contributing to the outcomes. Remember the outcomes: better household dynamics, seeking care for antenatal care, higher antenatal care, higher institutional deliveries than baseline, better dynamics at the household levels of referrals and so on. So the first objective was to assess men knowledge and recognizing danger signs during pregnancy, labor and delivery, postpartum care time, to determine if participating men were change their behaviors concerning healthcare seeking decisions at the household level, and to measure the health outcomes by increasing maternal and newborn care. As I said before, 20 communities and 20 control communities that were receiving other part of the project that I will mention later, but not were receiving this face-to-face counseling with men only. So these are the before and after. So in the column in your left, you will see the 2010, that is a 2010 baseline, and you will see these are the danger signs during pregnancy, knowledge, and these are 2012, the same danger signs that we asked, knowledge. And you will see the huge difference between case and control communities in knowledge. What is important about this slide? If you see the the danger signs that they were answering more, it was vaginal bleeding, hemorrhage, and signs related to preeclampsia or hypertension during pregnancy. So this was so relevant for us that they were not just telling us what we wanted to hear, but they really knew that during pregnancy, if the woman has abdominal pain, headache, blurred vision, that's a dangerous sign that they need to seek care immediately. These are the knowledge during labor and delivery, danger sign may knew or mentioned during labor and delivery, and see how the difference, how hemorrhage comes very high. So that's very important because that's the time when they can have any problems. And then prolonged labor, this is another one that they just mentioned that they didn't mention during the pregnancy. And retained placenta, that was another danger sign. So we knew that they really knew what to look for during the different period of the pregnancy of the wife. Postpartum period, look hemorrhage after the intervention. Fever, it came very high, that didn't come that high as in the previous responses. And the same headache, abdominal pain, blurred vision, smelly discharge, fever related to postpartum sepsis. So we were so happy to know that they really knew how to look for different danger signs in different stages of the pregnancy. But from knowledge to action, that's a huge gap. And you know, there are so many factors that so many people know things, but they don't practice it. So these are to practice the action, to really the behavior that men who were participating in the innovation was doing. Look in 2010, this is a husband who accompanied the wife to antenatal care and went into the delivery inside the antenatal care ward. And we have subsequent questions about asking questions during care, receiving a response from the nurse and so on. So the difference between the baseline in the case arm and the final evaluation and the control communities is almost went down. So that was, we were very pleased to see this. The second was the husband and wife who saw child care. When the newborn was sick, both of them went to the health center and see the difference between the baseline and the end line during the case arm, and the difference in the control communities baseline. And this one's beautiful. This is the husband who participated inside the delivery ward during the delivery of the child, the difference between baseline and end line, and the difference between the other communities, the other communities who were just control communities, and the other ones who didn't receive any kind of intervention from the project. This must be like a very good practice in the US, in other part of the world. But as I mentioned earlier, this is not happening in Nicaragua, it's still now. And it's a beautiful thing to see how the woman can choose, because by policy, the woman can choose who she wants to be with her during delivery. It could be the wife, it could be the TBA, the traditional birth attendant, or it could be any member of the family. But they always wanted to have the TBA, that's a traditional birth attendant, or the mother-in-law. For the first time, they knew that they can also count on their husbands. And this is the institutional deliveries. You can see here we have two separate blocks. The first one is Matiwas municipality, and the second one is Rio Blanco municipality. We decided to divide it because Matiwas is closer to the center of the country, and Matiwas and Rio Blanco is more closer to the Caribbean coast, very isolated community, and we didn't want to make a confounding of the findings, but still. You can see the before and after. This is the baseline for the case, very high, and this is the baseline for the case communities. And the difference between, these are the control communities, it went down, and also the communities without intervention of the project, it stayed the same. The maternity waiting home are so important, as you know, because those women, impoverished women who comes for far away, maybe 8, 7, maybe one day, by horse or walking to the health center, there is a place for them to welcome them, to stay there at least 15 days or whatever they can make it, because sometimes they can leave their kids and resources for too long. And excuse me. And this is important because they come earlier, they stay in the maternity waiting home, they receive antenatal care, they receive a daily checkup from the health center. A small team of the doctor and the midwives come to the maternity waiting home to check for how the baby is, the vital signs for the baby and the mother and so on. And when she enters into the labor and delivery, is transferred to the health center. So see the difference in the intervention area and the baseline 2008 and 2011. So the dimension of the interventions, you say, well, this is something new, because it's a systematic approach of using a male lens to understand the situation. This is new because for the first time someone is asking men their willingness to practice understanding their barriers, how they see the problem, what are listening to the enablers that they can mention to try new behaviors. As you know, fathers and husbands are the resource that is not utilized, it's not used. It's a huge resource for the communities, but they are not taken into the system. They are not included in the decision making in the system. Even in the baseline, they say that they felt left out, that they are not welcoming. So it was very enlightening for us to understand how they perceive the situation. It's crucial to create a supporting environment for these men because it's something new. This is something that they are trying that is supposed to be done just for women, and they really need a lot of support from the household level to the community, to the facility, in order to feel proud of themselves. And of course, as I said, this is a rural area, very impoverished, post-conflict area that we think that the household dynamics, a lot of violence, a lot of male-dominated situations, decision-making situations just made by men, that this approach could be applicable or adapted to other conflict areas or other rural areas with similar household dynamics.
Elena, did you ever have men who said they just did not want to participate, like maybe after the first visit you just had to walk away from that household, or did all the men respond positively?
Thank you for the question. Everyone was very excited, and I think a key factor for such a very well the men who were willing to do it because of the counselors. Who were these counselors? People who they trusted, people who were already doing the behavior, people that those men who were also becoming like a model for other people, other households, and they wanted to see that their household also becomes that they have the same thing that is happening to the household of the counselor. So we didn't have any problem with men saying no. We did have situation with women feeling that was their role, and now what am I going to do? So we had to consult them and also support them not to feel threatened that the husband now is going to wash the baby's clothes. That doesn't make her less of a woman in the household, but it's more like a sharing, household tasks, and making sure that they talk about it and they have time to devote to care and take care of the babies and so on. So we didn't have any difficult situations. We were very careful in the principle of doing no harm, because this is already that you are entering a household dynamic that is already fragile, that there are some maybe abuse situations, and we really needed to be very careful not to put the household in more problems or putting the women in more danger that they had before. So best practice, what we did was engaging. This is a good example of an innovation that is top down. It's not top down. It's an innovation that was developed from the community, with the household, with the men. So the men decided this is a situation, they recognized the problem, they saw a role, they wanted to try something so new for them, and it paid off because you saw the results. So we decided to involve everyone from the communities to the Minister of Health, the municipalities. Everyone was so happy and they were so contagious. They were participating, they were giving us all kind of resources to the maternity waiting home for people to have food. It was beautiful because everyone was contributing. It was like a wave of good vibe, and they wanted to contribute to. And I also wanted to say that it was just not with Catholic lay religious leaders that we work, but also Christians. So everyone who was involved in the community, we were respectful of their denomination and their faith. They were involved in the same, they had the same opportunity to participate. The lay religious leaders as a BCC counselors, or the men or the households that we work with. We decided to document and sharing the innovation with partner organizations. The donors, that is USAID, Washington was very pleased, and USAID in Nicaragua, the local mission, even included the approach in the RFA that was launched 1.5 years after we started the innovation. And so it was a way of also scaling up to other districts, to other NGOs who were also willing to apply to that grant. The challenge is the formative research took longer than expected, but it was worth it, because the learning curve that we had to do it with our own staff, our partners, Caritas staff, play a tremendous role in implementing and working with these counselors. And it took longer because it was made from the community. So it's not the same when you already have a tested document that you want to roll it out, that when you develop the document and you develop the approach with the participants. And what we have done now is we have developed a TOT guide and how to train counselors, and using the technique that we use, the counseling techniques approach and BCC materials. And we are also expanding the innovation. That is an intervention. It's not an innovation anymore, because we proved that it's good, it's working, and we are trying to adapt it to Ghana. So as you can see in this picture, we already went to the process of training the CRS staff in Ghana using the facilitator guide. This training also was used by myself to validate the document, to see if it was self-explanatory, if it was easy to read and also implement for people who hasn't done the innovation. We also went to 25 communities where we have our project, our child survival project in Ghana, and it started with the process, the same process, because the TOT guide doesn't give you anything. It gives you the guidance how to enter the community, how to talk to the community leaders first, in this case, the chief and the influential stakeholders who are the body who guards the traditions in Ghana, and then start selecting the BCC counselors using their characteristics. What do they see in a counselor, and so on. And then the men would be the men who have pregnant women or postpartum women. So in Ghana, so far we have negotiated with the Ghana Health Services, that's the Minister of Health, and in 25 communities going to be replicated. So do you remember our hypothesis? By focusing on fathers only, while not leaving behind the women, but also counseling, because this was a comprehensive project that at the same time we work with men, we work in community empowerment, we work with health centers in improving the quality of care, but also humanizing the care, making sure that the Minister of Health takes into consideration and is sensitive, culturally sensitive to the communities they serve. So we proved that our hypothesis was good, because in the final evaluation we found there was a perception of less domestic violence in the household. There was a perception of the women saying that they felt better, that they felt that their husbands were more loving and caring and supportive to them. We also approved the sales referral and the community referrals. When you saw the slides about antenatal care increases and institutional deliveries and essential newborn care. So we proved the hypothesis was proving that the approach was effective. So this is the model, the care intervention impact model, the CRS Nicaragua developed after this project. that has 3 lines that are parallel. So you work at the same time, father-focused counseling. You equip and train community health volunteers to evaluate pregnancy risk, refers to institutional care, become the first responders to obstetric emergency care, and at the same time, you go to the health clinics and work in humanizing institutional care, training Minister of Health in areas of need, capacity building to manage emergency obstetric care, and so on. And you will have the fathers have more knowledge, skills about maternal care. The salubristas, that's the community health volunteers, are organized, are implementing community birth planning, implementing and organizing themselves in what we call obstetric and newborn emergency transport teams. And the Minister of Health has the skills, technical and managerial, to provide improved environment for mothers, fathers, and families. And the service become more cultural sensitive. So as a result, we have increased joint decision about seeking care, more support to expecting new mothers, and more support to household responsibilities from the fathers, and improve healthy behaviors of household members before, during, and after birth. The communities with strong community organization, the teams organize the birth planning in place, a functional referral system, a very good coordination with the Minister of Health, and also the maternity waiting homes, and the health staff with the skills, providing high quality and cultural sensitive maternal and care. So thank you very much. I'm so excited every time I talk about this. It's so beautiful because I've been there, and I wish you could be there also to talk to those people. So I invite you to listen to the video when you can see the testimonies from different stakeholders, from the Ministry of Health, the community members, the counselors, and the participants. Thank you very much.
Thank you so much, Dr. McEwan. It's really encouraging to see how this project, which took a lot of time and effort, is really helping change communities, and how you've been able to take it to a completely different part of the world in Ghana and use it there. I think we have time for one question, and then we're gonna have to go straight to video. So this is kind of, if you can maybe do kind of a brief answer to this one from one participant. Let me read. Thank you, Dr. McEwan, for this very interesting presentation and the work you are doing. I am particularly interested in the replication of the intervention that you mentioned to be relevant in other conflict areas based on the preliminary experience in Ghana, and perhaps with the changes to the initial study itself. What, in using this in other communities, I think this is what the question is, what aspects do you think will be particular challenges for recontextualizing or doing this kind of intervention or project in another community?
Yes, thank you for the question. We've been working in Ghana for 2 years now with the Child Survival Project. And we use a similar approach to listening to the communities and listening to men and women in separate groups, listening to the TBAs and the chief and queen mothers, to try to understand the situation. Why in Tamale, that's the area that we are working in East Mamprusi, what is the situation that is contributing to the highest rate of number of maternal and newborn death? And then we found similar situations, similar household dynamics about who holds the compounds, who is in charge of the compounds. And there are more similarities that I've seen in Ghana and Nicaragua than differences. As I mentioned before, the guidance doesn't provide a recipe how to do it, but it gives you guidance how to enter into the community, and the key is to listening. You need to listen to everyone, and you need to listen to the men if you want to work with them. And also you really need to pay attention all the different things to try to do no harm to those communities.
You know, this is so encouraging. I love that listening part, and how that this project can be used in so many communities around the world to just, it's so life affirming and bringing the husband and wife together in a positive way that fits within their context and helps them make behavioral changes that are long lasting. So I want to just thank you again for your presentation. But Dr. McEwan, I had asked you earlier how we could pray during the next 30 days for these projects. Can you give us some specific ways that would be helpful?
Yeah, thank you for the question. I think us being people of faith, we always have our time during the day to pray to the Lord to help us, to give us strength, to continue supporting those people. And I think a special prayer would be for CRS in Ghana that is starting this new initiative in those communities, 25 communities, to give them the wisdom and the strength and the patience to work with those men with love and care, to making sure that more households have better household dynamics and make decisions together. And for example, in Ghana, there is one indicator that we really want to work on is involving the pregnant women in their pregnancy, because they are the last to say anything. As you know, the baby belongs to the families, the husband families, and they don't have a say about the pregnancy, seeking care, institutional delivery. So we are very interested in facilitating those processes of negotiation at the household level, to making sure that those pregnant women are also included in the decision making about their babies.
Thank you, Dr. McEwan, and we will be excited to hear what happens with the project in Ghana. Sounds like they have some additional challenges where the women have even less of a voice, and so we will just pray for openness on the part of the men and the leaders in the community, and just for effective insights for the promoters and others who are working within that community. So again, I wanted to thank you for joining us. If you would like to join the network, you can go to our website at herdignity.net and join our growing list of people who really want to affirm the dignity of girls and women, and as we have seen today, the equal dignity of men in being part of healthy pregnancy and healthy childbirth. So to all of you, we say thank you, and you are free to go now, but if you'd like to get just the last few minutes of the video, we're going to switch back to that. But Dr. McEwan, again, thank you so much for being with us today.
Well, thank you very much for organizing and giving us the opportunity to share this initiative. I'm just becoming the voice of these communities and people who were really doing the job day by day, and they are the ones who deserves all the merit.
Well, thank you for sharing what has been the work of so many people on the ground. If you'd like to know more about the project, go to our website, herdignity.net, and you can click through to information about the work in Nicaragua and elsewhere through Catholic Relief Services and this just amazing, wonderful, affirming project. So it's at our website, herdignity.net. And now we're going to go back to the last of the video.
Antes yo le reclamaba porque había cosas que tal vez no estaban a tiempo y no me interesaba en el asunto del cuidado de los niños, yo solo el campo, no me atrasaba en eso.
Agustín se refiere a la actitud que tenía antes de ser aconsejado por el proyecto de supervivencia infantil, ejecutado por Catholic Relief Services, con fondos propios y de USAID. La iniciativa apoya al Ministerio de Salud a disminuir la mortalidad materna e infantil. La innovación del proyecto es involucrar al hombre.
Queremos que esos hombres estén informados y que contribuyan a que su mujer embarazada o a la hora de tener el niño o a la hora de estar en la cuarentena pueda tener el apoyo del hombre y además pueda contribuir a tomar esa decisión de manera conjunta. El sentido de la jornada de esta mañana puede servir también de esperanza.
CRS, Cáritas y el Ministerio de Salud de Nicaragua implementaron la iniciativa desde septiembre del 2010 en 20 comunidades rurales del país, en los municipios de Matiguás, Río Blanco y Paiguas, donde se comienza a captar el interés y el compromiso de los hombres de las zonas.
La pareja es donde se debía de amar, es donde se debía de querer, respetar. Cuando nosotros, ¿verdad?, teníamos nuestros niños, miraba yo la necesidad, yo pues prestaba la atención, ayudaba para de que no hubiera esa deficiencia de que no dejarle solo el trabajo a la esposa.
Entonces yo me sentí gozosa y así yo pienso pues que es bueno que así los demás esposos hagan con las esposas, con sus compañeras.
Así es Nicaragua, así es mi país.
Involucrar a los hombres en el proyecto no ha sido tarea fácil.
Lo más difícil es encontrarnos con un hombre y dicen, no va a ir mi esposa a que la vea un varón, principalmente que es un médico que está en el puesto de salud.
El proyecto decidió que los promotores fueran los mismos hombres que concientizaran a otros. Una forma de generar más confianza. Estos líderes o promotores voluntarios de las comunidades se destacan por su buena conducta y van casa a casa buscando cambios de comportamientos.
Aquí estamos estudiando, capacitándolo para hablarle un poco más mejor de lo que estábamos hablando antes. Lo que hacemos, nos ponemos de acuerdo a lo que vamos a hacer. Primero hicimos el censo, después hicimos el diagnóstico, después hicimos las visitas para negociar con el hombre.
Los cambios comienzan desde sus casas. Félix Obregón es un promotor orgulloso de haber involucrado en el proyecto a su hijastro.
Como se está trabajando con los cambios de comportamiento, ya se está logrando. Se ha logrado a facilitar la confianza del hombre y la mujer. Por lo menos yo ya tengo uno negociado, que es mi hijastro.
Yo no sabía, pues cuando nació esta niña, yo no sabía que existía casa materna. Esta niña por lo menos fue partera. Cuando ya teníamos que andaba embarazada, ya me dijo don Félix que era bueno pues que ella asistiera a los controles a la fecha que el médico decía.
Él ha cambiado, me ayuda bastante, ahora con el niño me ayuda súper más. Sí, como dice él, estoy orinado, estoy ocupada, yo viene él, lo cambia, está llorando, lo chinea, cuando voy al río él queda, me ayuda bastante. Si no tengo agua, entonces él me dice siempre, pasado a ir a traer agua yo, siempre me ayuda.
A pesar del arraigo de los patrones culturales, los resultados sorprenden.
Las personas que no somos del campo, de alguna manera también hemos estigmatizado a los varones del campo y esa estigmatización impide que veamos con claridad su verdadero sentido y su cultura. Sin embargo, lo que han demostrado las familias y los varones es que ellos están abiertos al conocimiento. Lo que pasa es que también los varones tenemos temores, pero ya dando la información suficiente, el hombre se siente más orgulloso de su papel de hombre.
Los Martínez experimentan un cambio. Olman se ha involucrado desde el nacimiento de su segunda hija. La pequeña de 3 meses es cargada por su padre, mientras la madre prepara el almuerzo. Una imagen poco común en las zonas rurales más alejadas.
El proyecto es muy bueno pues por los consejos que le dan, cómo debe hacer la mamá, cómo debe hacer el papá, ¿verdad?, con el niño chiquito, ¿verdad?, que es importante porque por lo menos uno en el campo no sabe nada, está embarazada, pero tiene que llevar sus controles ella.
En los controles, cuando iba al centro de salud, él iba conmigo. Si yo me enfermo, él me saca, él va conmigo también. En el momento que iban a hacer la niña, él fue conmigo también, nunca me ha dejado sola. En cuanto a los trabajos pesados, él me ayuda a meter el agua, a rajar la leña, a adentrarla para adentro, a bajarme algún caldero que sea muy pesado. Cosas así pues que no puedo yo todavía, él me ayuda a hacer. Ellos tienen que involucrarse en los trabajos también de la mujer.
Bajo la cañada y no te importo nada cuando estoy aquí. Te doy mis tonadas.
Anabel tiene 8 meses de embarazo. Debe caminar largas distancias y bajar el río para lavar la ropa. Pero está feliz porque dice que su esposo ha cambiado desde que se ha involucrado en el proyecto.
Yo digo que es importante ese programa que está, porque hay veces los hombres son feos los modos con uno y ya con los consejos se van componiendo. Hay muchos hombres que a las mujeres cuando ya las miran embarazadas las miran feas, porque hay veces a uno se le mancha la cara y uno se mira feo pues embarazado. Entonces por eso no las quieren y las maltratan, dicen a buscar otras mujeres.
Anabel aprovecha que está en el río y lleva agua hasta su casa, una realidad que enfrentan las mujeres del lugar. La distancia para salir a un centro de salud es otra limitante. Por eso, los promotores insisten en la comunicación de la pareja para decidir atenderse en el centro de salud más cercano y evitar riesgos en la salud de la mujer y el recién nacido.
Algo muy interesante y muy bueno es que las mujeres, que son las esposas de los hombres, han valorado muy buena la participación de ellos, principalmente el acompañamiento de su esposo a los controles prenatales, cosa verdad de que ellos no lo hacían anteriormente. Principalmente en el municipio hay mucho machismo. Entonces ellos están convencidos de que sí vale la pena mejorar la salud de las mujeres acompañándolas a los controles prenatales.
Esta pareja caminó más de 3 horas hasta llegar a la unidad de salud más cercana para darle seguimiento al nacimiento de los gemelos que tendrán pronto.
Ellos vienen alegres y ellos dicen que ahora tienen esa oportunidad de ellos venir con ellas a asistir a su control. Incluso hasta la hora del parto también ya ellos han escuchado todo eso. Entonces ellos dicen que ahora se sienten pues felices que tienen esa gran oportunidad, algo que no lo tenían antes.
El proyecto apoya las casas maternas del Ministerio de Salud, donde alojan a las mujeres que están próximas a dar a luz.
Son de zona alejada, ¿verdad? De difícil acceso. Son personas muy pobres y que pues han decidido venir aquí a esta casa para poder tener su hijo en la unidad de salud.
Mientras estas mujeres esperan por el día de su parto, Pedro se dirige feliz cargando a su primogénita para que conozca a su nueva hermana. Es un día especial, por eso viste con su camisa que lo identifica como un hombre que ha cambiado de comportamiento.
Como antes nosotros no participábamos, ahora participamos, ¿va? Y entonces estamos más organizados.
A raíz de que entre este cambio de comportamiento por CRS, se ve la afluencia de las mujeres hacia el parto institucional. Están más pariendo a la unidad que en su domicilio. Y lo más importante que involucra al hombre.
Hombres y mujeres reconocen que los cambios de comportamientos fortalecen la unión familiar e inciden en la actitud que sus hijos tendrán al ser adultos.
Dice, mi papá trabajó para cambiar y vivir bien. Eso es lo que queremos, vivir bien.
Esa es una alegría que los papás pues apoyen a nuestros niños, porque ellos sin el apoyo del papá no son nada. Sí, es bueno que los hijos se críen con el calor de su madre y de su padre.
Cuando el padre establece una comunicación periódicamente con él, cuando el padre de familia incluso transmite sus sentimientos de cariño y de amor para con el hijo, entonces va acrecentando su dignidad de persona.
Los involucrados en el proyecto se muestran comprometidos con los objetivos de la iniciativa, aunque reconocen que requieren más tiempo para lograr los cambios de comportamiento en la mayoría de los hombres de las zonas rurales del país.
Lo mejor es que se extienda más y si es posible abarcar más comunidades, porque se ve que en las comunidades donde está el proyecto los hombres están más sensibles.
Un cambio así no lo vamos a ver en tan poco tiempo. Entonces, con más tiempo, más seguimiento, más acompañamiento de los promotores, creemos que es posible. Queremos que se extienda a nivel de todas las comunidades para ayudar al municipio a disminuir las muertes.
Yo me siento contento con el cambio que he experimentado, pues. No se logra, pero hay que ir poco a poco, ¿sí?
Yo creo pues que cuando uno está embarazada es cosa de hombre también, porque el hombre debe ser responsable con su hijo. Y ahora que nazca mi niña, yo sueño que mi marido, cuando yo venga a lavar, me cuide de mi niña, me ayude a hacer las cosas, porque ya uno es diferente para hacer las cosas con los niños. Me lo cambie el pañal y todo eso, me apoye.
Es importante porque, como le vuelvo a decir, allí se dan cuenta los varones que no es solo cosa de la mujer, que también ellos lo pueden hacer.
Mientras tanto, las beneficiarias del proyecto tienen la esperanza que otras mujeres, al igual que ellas, puedan tener el respaldo de sus parejas.